I think there are many ways how we can optimize the treatment. So first of all, we need to look at induction and consolidation treatment. And within there, it's important to emphasize that many trials, the GMMG HD7 trial, as well as the Cassiopeia trial and the Griffin trial, showed compelling evidence that a quadruplet regimen for induction and consolidation should be used in transplant-eligible patients. Secondly, we should try to stick to autologous stem cell transplantation, because in the majority of patients this really adds a huge benefit and is a well-known and well-established treatment. Lastly, and that's an open question, is how can we improve maintenance treatment? Currently lenalidomide is the standard of care, but I'm sure that we will see results from the Perseus trial and the GMMG HD7 trial trying to answer the question whether we can add an anti-CD38 monoclonal antibody to lenalidomide.